Hey guys, welcome back to Medical Coding with Blue. Today's episode is all about abstracting versus auditing in medical coding. What do they mean? If you are brand new to my channel, welcome. I am Blue. I'm a medical coder. I have been a medical coder for over 10 years. I have so many stories and tips and tricks. I created my channel with the hope of sharing all of this with you. So if you're interested in learning more, I hope that you will hit that like button, and I hope that you'll subscribe, and I also hope that you will share this with somebody else. All right, so let's get started. Okay, abstracting. What does this word mean? It means to remove or take away. In the setting of medical coding, abstracting means that we are looking at documentation and we are able to look and spot diagnoses that we can pick up that are applicable for this particular visit. Sometimes providers will have already pre-chosen their diagnoses and pre-chosen their procedures. This does not mean that these are correct, because some people may say, "Whoa, wow, that's so easy. He already does or she already does all of the diagnosis selection, so I don't have to do anything." Au contraire. No, you have to review those because there's a lot of these other little rules that we know as medical coders that doctors don't know. Remember, the doctor is not supposed to be, or the nurse practitioner or the PA, they're not supposed to be the ones that are coding. They need to concentrate on documenting, okay? But like I said, they have to sometimes select the diagnoses, so we have to go in and make sure that they are sequenced correctly. We have to make sure that they are selecting the most specific diagnoses. Now, if they are not, you can work with them to try to get them better, but I don't recommend harping on them when it comes to that. What I really like to focus on is for them to document fully, because it's my job to be the coder and to be able to get the diagnoses and get the procedures and pick them up correctly. Would it help if doctors or providers are selecting the correct diagnosis all the time? Sure, but they have so much to do that in the scale of what is most important for them to do, the documentation. Because if the documentation is there, then I, as the coder, can make sure that everything gets selected appropriately. So that is where I focus my energy with them. And I let them know, I'm not going to get after them for little things, but I am going to make sure that they are in the ballpark, okay? That they don't have to be so completely off, but at least we are in the ballpark so that when I'm making corrections or whatever, it's not so many, or maybe it's just here and there. So it's really going to depend on the relationship that you have with your provider. But I always harp on relationships because they're very important when it comes to being able to abstract quickly diagnoses and procedures, because when you really understand what the provider is saying, you're able to move through the documentation much more quickly. Now, when you're abstracting, you are looking at the entire note. Let's just talk about the outpatient side. I'm not talking about inpatient coding. I am only talking about the outpatient side because to me, it's much easier to explain this. And especially to brand new people, it's much easier to explain outpatient. So we have an encounter, right? This patient comes in and we're looking at the entire date encounter on one page, right? It's just a one pager. And they're talking about the history, they're talking about the review of systems, physical exam, and their assessment and plan. Now, in their assessment and plan, maybe they have like one diagnosis selected, but throughout their note, there's other pertinent diagnoses that the provider is addressing and that affects this patient's care. If this is the case, then those diagnoses would be applied, because anything else that is affecting this patient's care, say for instance, they have a broken leg, but they also have a blood clot, okay? You're gonna have to pick up that blood clot, not just the broken leg, right? So that is very important to know. If the patient is also a diabetic, this is also going to have to be selected as well, because diabetics tend to have a slower healing process if their blood sugars are not under control. And as an orthopedic provider, they're going to make sure that this patient's blood sugar is under control. Maybe they reviewed the labs, or maybe they looked in the last time they had a blood sugar draw. And if they haven't had one in a while, of course, they may send them for one. So these are factors that also play a role in this patient's care. This is why these things would be included in conjunction with this broken leg. Now, if the provider only selected broken leg because he's an orthopedic surgeon, so he's only going to pick up the bone work, okay? But all this other stuff goes along with that bone work, right? Because this patient, every patient is individual. So this patient has diabetes and has a blood clot. So you have to make sure that they're okay, they're doing okay on their anticoagulants, because if they're bleeding, this can be an issue if this patient is being casted, okay? Something else to think about, right? So all of these things play a role. So if the provider did not select the blood clot and the diabetes, that would be abstracted from the information that you get from the documentation, because the only way we know this is, in theory, that the provider documented it in the note. He could have put it in his history part and maybe didn't bring it down to the assessment and plan, but this can also be picked up because it is directly affecting this patient's care. It was addressed on this day, and that's how we know. That is what abstracting means, okay? And auditing is right behind it, okay? So auditing, like I said, the provider only picked up one diagnosis for the broken bone because, again, orthopedic surgeon, he's only going to want to pick up the bone work. So this would be considered incorrect if we're doing auditing. And not that you have to go and tell the provider, well, you know, this is when the opportunity for education comes into play. This is when, okay, sir, ma'am, you can also pick up the diabetes and you can also pick up the blood clot because this is directly affecting this patient's care. And if there's extra medical decision making that goes into it, this is going to move into evaluation and management if this patient is in a global period, okay? That blood clot and the diabetes is something completely separate from that injury, okay? So that is when that evaluation and management is going to come into play, because if you are seeing a patient who is in the post-op period, and I know I'm kind of going from subject to subject, but follow me. When a patient has had a casting for this broken leg, right? And they're in this 90-day global period. This means all of the visits for that broken leg are covered, right? So if the provider has to see the patient for something else outside of this broken bone, this is something completely separate. Well, now this same patient has a blood clot, and we don't know why this patient has a blood clot. I'm just thinking this off the top of my head. But this patient has a blood clot, and it could be related to something else, or it could be because of a condition that they already have. I mean, it could be anything, okay? But this is completely separate. And they also have this diabetes, okay? Again, not related to this injury. So as long as the provider is documenting correctly that he's reviewing the blood sugar labs, or maybe he's having to order additional labs to make sure, or maybe he's talking to this patient about making sure that their blood sugar is under control so that they can heal appropriately and on time. And same thing with their with the blood clot, because if they're on long-term use anticoagulants, that's that INR level is going to play another role in that as well, because you can't have a patient with, you know, out of control bleeding either when they have a broken bone. So all of those things come into play, but that is how abstracting and auditing are they really do sort of coincide with one another, okay? Because especially if the provider is just picking up only certain things because that's all they think that they're allowed, then that is something that they need to be educated on. Because sometimes these providers, they don't know. They don't go through a coding course. And you will find some ambitious providers who do go through medical coding training so that they can train themselves. And to me, this is really good. And it's kind of sad in a way, because if a provider is doing this, Maybe because they've never had somebody to sort of help them to sort of see. And a lot of times coders, unfortunately, get intimidated. And if a provider gets gruff with them, maybe they'll just say, well, he wants this or she wants this code, so I'm going to go ahead and give it to them. When this is not right, you have to be willing to stand up for yourself, and you have to be willing to look at their documentation and code it appropriately. If you have to go against something that the provider says because their documentation is supporting your code, then that is something that also needs to be addressed when you're talking about educating this provider. And you don't want to go at them full force, telling them you're doing this wrong, you're doing this wrong, you didn't select this, you didn't select that. They don't know. This is why you have to be patient enough with them to sort of walk with them on this journey and help them to see why this is important. I've gotten the brunt end a lot of times of, why do we have to pick up diabetes? Why is this important? Why is a blood clot important? I'm like, are you not looking at their blood sugar levels? Are you not doing all of these other things? Well, yeah, it says it right here. Okay, that's why I have to select these diagnoses. That's why I have to change this procedure code to this, or this is why I have to add an E&M code for this. So all of those things, they're like, well, I didn't know that. Well, and so it takes somebody to be strong. You have to be strong enough to stand up to these providers and say, respectfully, of course, I'm adding this diagnosis, or I'm taking these diagnoses away. Sometimes they may be selecting diagnoses because somebody else told them, or maybe they heard from another colleague that they code it this way, so they're going to do this. And that's when it gets to be a little like you have to be very clear. And I'm very clear with my providers. I tell them, I am here to help you. The only way that I can help you is if you work with me. And the only way that you work with me is by following this very easy to follow guidance that talks about the reasons why we're picking up this code or why we are not selecting these codes. But then sometimes you get providers that will go to a colleague and then they'll say, well, my colleague says that we should do this. Okay, I don't know where your colleague is getting this information, but I'm the coder, I'm your coder, and this is the reason why. So always be sure to have your backup. You need to have your information as to why you are selecting or removing these codes, because not to scare you guys, but providers can have reports run for all of the encounters that they do, okay? So it'll have a category for all of the codes that they selected, and then it'll have a category for all of the codes that the coder selected. So if there's like a green check mark that they're both in agreement, then everything's good. But then when you start to see the provider's codes versus the coder's codes, and if there's a change, then you may get a provider that may come knocking and be like, what the heck? Why are you changing my codes? This is when you can explain the difference between abstracting and auditing. Auditing is just checking to make sure that everything is good and makes sense. And if it does, then great. Then you know you have a very well-trained coder, a well-trained provider. But if not, then that's when you guys have to really start communicating on a much more deeper level, because there's a disconnect. Clearly, if a provider is not really understanding why, there's a disconnect, and you really have to kind of figure out how do they get communication? Like, are they visual learners? Are they auditory learners? You really have to sort of kind of figure that out. And it takes just sort of making sure that you're paying attention to their cues, because a provider will let you know really quick if they're being receptive or if they're telling you to pump the brakes. So that being said, our job as medical coders is to make sure that all of the appropriate codes are selected. And this, in turn, we have our providers' backs when we do this. When we allow the providers to say, I want this code, you will select this, and the coder just sort of gives in because they don't want to argue, that's not the right way. And that's unethical as well. We cannot code based on like, you will do it this way. What is there is what we are coding. Okay, so never just take the codes at first glance. Double check the documentation to make sure that those codes match up to what is happening in that visit. Okay, because like I said, sometimes you will have very straightforward visits. The provider knows what they're doing and they select the codes perfectly. But then on those other times when you have to do a lot of changes, you may have to take some time with them and say, okay, let's talk about why I had to make all of these changes, But like I said, don't harp on them about little things. Sometimes they may pick up just like status codes, or like history codes. And I mean, if you need to leave it there, if it makes sense, if there was like a history of military deployment, you may have to just leave that one there, because sometimes if it's related to what's going on with this patient, then that would be appropriate. If they're coming in for a cold and they say, well, they have a history of military deployment, well, okay, how does that have one to do with the other? Did they talk about that? Or, does it really pertain to what is happening with this visit for this patient who just has a cold? That is when you're like, okay, well, maybe that information is not really pertinent to this cold. Okay, so it's very straightforward, and that's how you start to look at all of these things. And again, sometimes they may pick up additional diagnoses, thinking that the more diagnoses they have, the higher their levels. But always make sure that those additional diagnoses that are being picked up are pertinent to what is happening with this patient. And it is needed for like medical decision making or medical, I was going to say medical decision making again, but you have to make sure that everything that is being selected is appropriate. Okay, that is the bottom line, down to the procedures and the diagnoses. So that is the ins and outs of abstracting and auditing. Again, it's, we use auditing, we use the word audit in a couple of different meanings as coders, because we get audited, right, on all the codes that we're selecting, and we get our charts looked at by a supervisor or a lead or somebody in data quality, and we get our audits, okay, and then we as the coders can audit the providers as far as like what they're documenting and the diagnoses that they are selecting. So this word gets used a lot, auditing, And then abstracting. Abstracting is used a lot as well. If we are looking for a certain population of people, like say for instance, we're looking for in our facility, right? Just a general facility, they're looking for smokers. Everybody who smokes cigarettes, okay? Because there's dip, there's cigarettes, and there's vape. But they just want to abstract all the information about cigarette smokers. What is some common things that happen with them? So they'll run reports with the cigarette smoking code, right? The F17210, okay, dependence on tobacco cigarettes. And then they can look at all of the diagnoses that affect these patients, okay? Or they can look and see if maybe they've had delayed healing, and which is common for patients who smoke or do any kind of tobacco products. They tend to have a slower healing process. So they can do a lot of really good work when it comes to getting information from the data that is collected when codes are being applied appropriately. This is why it is so important. And yes, I know it's a lot. It is like, how do you know? And it's so much. And you're just looking, and should you pick up everything you see? You got to pick up what is what is involved in this visit, what is pertinent to this patient's care. Again, going back to the patient with a broken leg and diabetes and blood clot. Both of these things, oh yeah, they can have an effect on that broken leg. They can really slow down the healing process. So, or they can make it worse, because think about it. That broken leg has to be in a cast. That cast, they can get ulcers, right? Skin ulcers. Well, if you're a diabetic, skin ulcer is a very bad thing. And then if you have a blood clot and you're on blood thinners, now you've got a weeping wound. There's a lot of things that can happen when a patient has other conditions and with something that you might think is so benign as a broken leg. So the body is an amazing thing. This is why physiology is huge in medical coding school, because you have to understand the disease process. You have to understand like the basics of diabetes. You know, if the blood sugar is too high, a lot of things can happen. And it starts to affect your organs, and it starts to affect a lot of different things. And it's not just one organ system. It is affecting lots and lots of organ systems. It affects your nerves. It affects your kidneys. It can affect your eyes. There's lots of things that can happen with diabetics. And then is it type 1 or is it type 2? That's also another factor into it as well. Are they on long-term use insulin? Are they on long-term use anti-diabetics? That's another thing as well. So a lot of things can go into these things. That's why physiology is huge. Anatomy is huge. These are all very important, and everything sort of blends in after a while. And after a while, you'll get it, okay? Because a lot of people are just writing me in and they're like, Bleu, I don't understand. What do I really have to know anatomy and physiology? Yes. In order to understand what you're reading and how everything affects everything else, oh yeah, you have to understand that. So, you know, that's where it gets interesting, because then you're like, ooh, you know, well, if I learn this, what else can I learn? That is why I tell you guys, reading like case studies in the New England Journal of Medicine is really good for that. Now, this is not an ad for the New England Journal of Medicine, but this is what I read on the weekends. And a lot of times they have case studies. So me, my coder brain immediately goes like, okay, we got a case. We're looking at a case. So I immediately start looking, and I am coding this thing out, right? I'm looking at all of the conditions that the patient has and what are their symptoms, okay, and then what does the final diagnosis say? So in my head, I'm already coding all of these things out, but just by reading these things and practicing looking at what is important here, what is affecting this patient here, that is how you get better at abstracting, okay? That is how you get better at auditing. That is how you get better at looking at documentation as a whole, okay? Because it is not just about, well, I'm going to start at the history, and then I'm going to go to the review of systems and the physical exam, and then down to the AP. Me personally, my pro tip, if you want to call it that, I look at the assessment and plan first. I always look at the last of the chapter, right? When you're studying in school and you're reading, right? And you start off in chapter 1, and then you have your little quiz questions at the end of chapter 1, right? And then you think about, well, you know, yeah, I read that. But what I do is I read the quiz questions first, then I go back to the first part of the chapter and I start reading. Because in my mind, I already have in my head what questions are they going to ask. That's how I know. So I adopted the same idea with looking at notes. A lot of people will start at the history. Now, a few years ago, my memory started to get bad, okay? I was like, I was starting to forget things. Turns out I had really low vitamin D levels. So that vitamin D is really big when it affects your memory, okay? So anyway, that is something that, just in case you didn't know, it's a fun fact. But yeah, so anyway, I'm looking at the documentation. That's why I said, let me start off with the assessment and plan, and that way I know what I'm looking for. So I started to do that. Well, wouldn't you know, it started to help me pick up the pace, because then I was like, okay, now I know exactly what I'm looking for. I'm looking for a fracture. I'm looking for some other injury, and I'm looking for a blood clot, okay? And then I would go back and look at the history, okay? And then I would discover, uh-oh, this is a diabetic patient, or uh-oh, this is a hypertensive patient, okay? And they're talking about all the other stuff that they're doing in the history. Sometimes they'll do that. You know, providers, they're not going to be having streamlined documentation all the time. So sometimes they may talk about it in the history, but not drop it down to the assessment and plan. So that's when you can say, okay, now I know what I have to include. So we know we're looking for an injury, or we're looking for like the diabetes, and that's how we're able to find these things. So keeping that in mind, you know the end result, you know what you're looking for. And then you can kind of figure out what the evaluation and management level is going to be, because you know that their medical decision making, what they've already decided that they're going to do. So now you have to just go and make sure that everything else in the documentation matches up. Again, that's part of your auditing process because you're making sure that everything is there. So, and your abstracting process, because if you need to pull out additional diagnoses to add, again, you see how that sort of goes together like that? I hope this was a good explanation. I hope it was. Anyway, because sometimes I think about these things and I'm like, this is how I would explain it. So if this helps, I hope it did. Anyway, but I'm going to go ahead and wrap this one up because it's getting kind of long. But we got another episode. I'm going to be talking about edits tomorrow, so I hope you'll join me then. All right. So if you are a medical coder, a medical coding student, somebody curious about the fascinating world of medical coding, a provider or a nurse, I invite you to like and subscribe and follow me on my journey in medical coding. I will see y'all next time. Bye.